Ladies and gentlemen, on behalf of InVivoScribe, we welcome you to this corporate workshop organized by the Association for Molecular Pathology. Today's webinar's title is NGS Assessment of Somatic Hypermutation in CLL, SLL, a practical comparison of platforms and primers. I'm pleased to introduce our speaker for today, Dr. Kseniya Petrova-Drus, Assistant Attending Pathologist at Memorial Sloan Kettering Cancer Center. Dr. Petrova earned her MD and PhD degrees from NYU School of Medicine. She completed residency training in anatomical and clinical pathology, as well as a hematopathology fellowship at New York Presbyterian Hospital and Weill Cornell Medical Center. She then went on to complete a molecular genetic pathology fellowship at Memorial Sloan Kettering Cancer Center, where she has been practicing as a molecular hematopathologist for several years. She's board certified in both hematopathology and molecular genetic pathology. Before I turn over the webinar to Dr. Petrova, I would like to encourage you to ask questions in real time using the chat feature so that we can address them at the end of the presentation in a question and answer session. I'm now pleased to turn over time to Dr. Petrova for her presentation.
Thank you so much. Thank you so much for that kind introduction. And also thank you to AMP and to InVivoScribe for the opportunity to present our work. Let me see if this is progressing. Yes, so this particular study we had just recently published in the Journal of Molecular Diagnostics, and I will go through it in detail in this presentation and hopefully address any questions you may have. But if you have additional things that may be unclear, please go ahead and review our manuscript, and if you could also email me if there are additional questions that may be unanswered. And I want to also take a minute to acknowledge all of the co-authors listed here. And I do want to mention, for the sake of disclosure, that although we had partnered with InVivoScribe for a limited number of sequencing that was done for this particular work, the study was done independently by us without financial support from InVivoScribe or any other significant bias for this work. So I'll give you a brief outline of my presentation. First, I'll briefly talk about CLL and somatic hypermutation, and just to give you by way of some background, and then I'll focus in detail talking about the two arms of the way we had conducted our study. So the retrospective arm, where we did platform and primer comparison, as well as a prospective arm with our implementation branch. So I'm not sure how many of you in the audience are pathologists and are familiar with chronic lymphocytic leukemia, which is also known as small lymphocytic lymphoma, it predominantly affects lymph nodes or tissues. But this is a disease of mature B cells. They are clonal and tend to be small or intermediate in size, and they typically involve peripheral blood, bone marrow. They could involve other lymphoid tissues like lymph nodes or spleen, and this is the typical morphology that you see when it involves the lymph node, with effacement of the normal architecture and proliferation centers that are also characteristically seen. Immunophenotypically, CLL tends to be CD5 and CD23 positive, as well as additional other markers. And importantly, patients with this disease tend to have a broad range of disease course. Some patients do well for years without requiring therapy, while others may progress and succumb to their disease pretty rapidly. So over the last 40 or 50 years, there have been a number of studies that have identified different prognostic factors that help us to understand which patients require therapy early and which can be watched for a number of years. And these prognostic factors include age, rise staging, chromosomal abnormalities within the neoplastic B cells, as well as the P53 gene functional status. But in the last, about 30 years ago, an important study came out by Hamblin et al., and they identified that the mutation status of the of the immunoglobulin gene, of the rearranged immunoglobulin gene, was also an important prognostic factor for this disease. They observed that patients with an unmutated status tended to do much worse, with a median survival of approximately 8 years compared to those patients that have a mutated status of their immunoglobulin gene, whereas their median survival was about 24 years or so. So since this initial study came out 30 years ago, a slew of other publications came out, and they effectively confirmed these findings. And more recently, there have been international prognostication indexes that have looked at the importance of the somatic hypermutation with respect to other factors in a multivariable models. And the unmutated status continues to be an important negative adverse prognostic indicator for this disease. And more recently, as additional therapy has been implemented for this disease, we now know that it's also predictive for treatment, so that patients that have a mutated immunoglobulin gene rearrangement status, they tend to have longer overall survival when they're treated with a chemoimmunotherapy, fludarabine, cyclophosphamide, and Rituxan, whereas those patients that have an unmutated status of their immunoglobulin gene rearrangement tend to respond better to ibrutinib-based treatment than to FCR. So we know that this is an important prognostic indicator for this disease, but just to give you some background of what exactly it is that we're measuring. So as you're probably familiar, B-cell differentiation happens in the bone marrow, and during that process, we have the germline configuration of the immunoglobulin locus, which consists of a number of different V, D, and J genes, and those rearrange to form the completed the rearranged gene that will then make the immunoglobulin molecule. And the rearrangement process first happens with the D and J genes recombining, followed by rearrangement to the V gene as well, to create that large diversity of antibodies that we're all able to mount when we're faced with an infection. And additionally, during this recombination steps, you have additional insertion and removal of non-templated nucleotides at these junctions, which is mediated by TDT. And then once you have a mature B cell that's found in the circulation, whenever it traverses through the germinal center, it will undergo additional somatic hypermutation substitutions, which will further diversify the immunoglobulin gene, creating further diversity and also optimizing it for the purposes of reacting with the with its antigen. So this particular this status of somatic hypermutation is what we're interested in detecting for this disease, because as I mentioned, it's been known that those patients that have a mutated status tend to do better prognostically than those with an unmutated status. So conventionally, the way that this was measured was looking at either mRNA, cDNA, or genomic DNA, and the clonotype is amplified by PCR using the Biomed2 primers that have been established. And this particular conventional methodology requires a high neoplastic content and a low background, so that you could actually sequence then this predominant amplicon directly by Sanger sequencing. Now, this method is technically challenging and labor intensive, and not routinely performed in every molecular lab. There's also complications, because if you have two clonal rearrangement, two bands, then you need to cut them out, you need to purify them by gel, and before you could proceed with Sanger sequencing. And in such cases, If you have low level of amplification, you may also need to subclone into plasmids before sequencing. So in overall, this conventional methodology, you could have up to 10% of cases or even 9 to 18% failure rate that has been published in the literature. So this is, as I mentioned, it's a technically challenging and labor-intensive method. It requires manual data analysis for the consensus read, and it's not a high throughput methodology. But the conventional, all of the current evaluation of somatic hypermutation is based on this conventional method, and there have been a number of guidelines that have come out over the years as far as how to evaluate this, because this is technically a very challenging interpretation. So the current expert guidelines recommend using leader primer, and I'll show you what I mean in just a few slides. So they recommend using at the 5' end using leader primers versus FR1 or other downstream primers. They recommend a multiplex PCR reaction and then detecting either by gene scan or phage electrophoresis. They do mention that cloning is not necessary, but we know that that really depends on your amplification. And then when it comes to sequencing methodology, the recommendations are that this is done direct sequencing with sequencing of both strands to be able to evaluate. And they do acknowledge that these guidelines do acknowledge that there can be some difficulties. And before I go into that, I do want to just clarify that the unmutated status is defined as having 98% or more sequence identity to the germline configuration, so that when we look at when we translate that to a mutation rate, which is what I'll be referring to, that means that anything with a mutation rate of 2% or lower is considered unmutated. On the other hand, mutated CLL is defined as having less than 98% identity or greater than 2% mutation rate, but with a caveat that those cases that have a mutation rate of 2.1 or up to 3%, in other words, 97 to 97.9% sequence identity, those fall into this borderline category. And that borderline category is really signaling that those cases, the prognostication for those cases is not exactly clear cut. And those cases are sort of require additional follow-up, and it's not really clear exactly how to approach those at this point. So the consensus guidelines also acknowledge that there are difficult cases. So as I mentioned, you could have instances where there is more than one clonal rearrangement that you're able to identify, and conventional methodology has identified that at approximately 10.5% of the time. And these can have different combinations. You could have a productive and non-productive rearrangement with where the concordant status, where they're both mutated or unmutated, or they could have discordant status. And I do want to just clarify that when we talk about the prognostication, we're talking about specifically in reference to the productive clonotype, to the productive sequenced rearrangement, because that's what's been conventionally studied and conventionally has been identified as significant for prognostication. And so a number of guidelines have been published over the last several years. This table is from the 2017 guidelines, but also an updated publication came out just recently in 2022. So with this, the importance of evaluating somatic hypermutation and the difficulty of doing this by conventional methodology, with the advent of NGS, it really presents a very attractive way to evaluate this. We know that NGS is also amplicon based for this particular assessment, so it's similar to the traditional method. It has an additional advantage that when you're sequencing, you're able to separate the fragments, the amplicons, based on the actual clonal sequence as well as the size of the fragment. In addition, when you have a number of different barcodes, you can multiplex and evaluate multiple samples at the same time. So really it has an advantages in throughput. And the consensus sequence review is much less manual than conventional methods, and also it's a more sensitive detection of the clonotype than the conventional method, which requires that the neoplastic content be quite high. So there is a lot of advantages to understanding how we could transition this conventional analysis to the NGS methodology. And that's what we were interested in trying to evaluate in our study. And for this work, the NGS assay that we used is as a commercially available kit. This is the in vivo scribed lymphotract assay. This kit includes two options. You could either have FR1 based analysis, which detects, which is a multiplex primer set that anneals to this portion of the V gene, or you could have leader based sequencing, which is just found upstream associated of each V gene. So those are the two options. And as I mentioned before, the current recommendations is that leader sequencing is used. So we were for this purposes, we wanted to understand, can we what are the differences between using these two primer sets. So the workflow for this particular kit, for this particular evaluation is, of course, it starts with DNA extraction. We then proceed with PCR amplification using the multiplex consensus primers. We sequence it on the platform of choice. As I'll show you, we use two different platforms. And then the subsequent output is analyzed by the software provided by the company. It's proprietary, but it allows for grouping and merging of sequencing to identify different clonotypes, and then those are compared against the reference databases, in this case, IGBlast. And then the subsequent output could be used either for calling of the clones based on the thresholds that are established, or you could also, if you already have a clone that's been characterized, a clonotype that's been characterized previously, you could use it for disease monitoring. But I will talk only about the characterization of samples for the purposes of this presentation. And for those of you who may not be familiar with the output of this particular assay, here's just a screenshot of what it looks like. We have different sequences with different ranks. So this gives you the entire sequence of the amplicon after primer trimming. This is the length of the amplicon that's evaluated. It then gives you what was the number, the count number, the merged count number of that particular amplicon of the particular clonotype, gives you the VG, gene usage, the VGA, sorry, usage. And then importantly, it also provides with the percent of the total reads for this particular, for your dominant sequences or for all of the different sequences that are detected. And importantly, for this evaluation of somatic hypermutation, we need to know what is the mutation rate compared to the germline. And this analysis is IGBlast based. And of course, as I mentioned, we are only interested in the productive sequence for the purpose of prognostication. So we need to know what is the productive and unproductive status for the specific clonotype. So this is what the typical output is. And how do we decide what clonotype meets our clonal reporting criteria? So this in itself is also required a significant amount of work from our lab, and the criteria that we use for clone reporting have been published in this publication by Dr. Maria Arcilla in 2019, and this was based on our experience in the laboratory. So we use the criteria that are listed here. So in an optimal case, we want to see more than 100,000 total reads, because we want to make sure that you have enough amplification there, so that you're not dealing with something that has low amplification and maybe calling pseudoclones. So we're based on our experience, we think 100,000 it was the optimal total number of reads. And in this in this setting, in order to call something clonal, the dominant sequences should be more than 2.5% of the total reads, and at the same time be 10 times the background. So we sort of decide which rank represents where the background starts, and you want these to be 10 times more. And then you could identify either a single clonotype, or if you see that there's two dominant sequences, then it may represent a biclonal or biallelic rearrangement, which has been reported in CLL. So in instances where you may not reach the 100,000 criteria, and actually we, based on our experience, more than 50,000 is also suitable. But in cases where you may not reach the optimal total number of reads, qualified results may be interpreted in cases where there's at least 30,000 reads. And here we would want in order to be sure that this is something that's clonal and not a pseudoclone, we've found that having more than 5% of the total reads is acceptable, but then we want to see it at being more than 20 times against the polyclonal background. And in our experience, a failure was considered if the total number of reads was less than 30,000. So this is the scheme that we had used to evaluate all of these cases. So the sequencing platforms, as you're probably familiar, the two that we tested in this study included the ion PGM, which is an emulsion PCR-based assay that where the templates are prepared on beads. The sequencing is performed in a nanowell in a semiconductor chip, and it utilizes pH measurements to read out the nucleotide sequence. On the other hand, Illumina-based sequencing, as you're probably familiar, is bridge PCR on a solid surface that generates template clusters. Here, the sequencing by synthesis utilizes fluorescently labeled reversible chain terminators, and it's the detection of this fluorescence that allows for reading of the nucleotide sequences. So now for our study design, we had, as I mentioned, we have two arms. We have a retrospective cohort that we used that included 35 archival samples, predominantly peripheral blood. And these we studied by the ion PGM with FR1 primers, the MiSeq with leader in FR1, and then we used as a reference for comparison Sanger, a standard Sanger-based method. And I'll talk about the prospective cohort a little later. So, but before we can compare the somatic hypermutation rate, it was important for us to understand, well, how do the various platforms and primer sets, how do they actually compare with respect to the clonotypes with respect to this output? We can't really compare the mutation rates unless we can confirm that it's the same clonotype that's identified by these different platforms and primers. So this was, as I mentioned, these 35 samples that were evaluated 4 times. So for PGM sequencing at the time of the study, only the FR1 primer set was available. So for platform comparison, we used the FR1 primer set to compare MiSeq versus PGM. And then we used the MiSeq platform to compare leader versus FR1 sequencing primer sets. And then we also compared it to the reference Sanger-based method. So this is the summary table of the output. And on top here, you'll see all the different frequencies of the clonotypes. And then here it's a color-coded output of the different clonotypes that were detected, whether they were productive or unproductive, mutated and unmutated. And just overall, when we compared the reference to the overall NGS methodology, we found 100% agreement with respect to the detection of the dominant clonotype and the qualitative somatic hypermutation status, so mutated or unmutated, that was that had 100% agreement. However, when we compared the reference independently to the different NGS methodologies, we did see that there were some discrepancies. So there were 3 major discrepancies. One was a failure when it came to leader sequencing, and this as you'll see, even though it failed leader sequencing, when we looked at those reads, we could still see that clonotype, but just not meeting quantitative criteria. Then another failure was a sequencing error in PGM that I'll discuss in detail in the next slide. And then there was another discrepant mutation status case where the reference methodology had unequivocally mutated status, but NGS methodology by FR1, it was unmutated, and by leader, it fell into this borderline category. So these were the major discrepancy that we took note of. There were additional minor discrepancies where additional clonotypes met quantitative criteria by one method and not the other. And there was 7 a total of such cases, and they're highlighted here in yellow. But then we went on to now compare specifically NGS to itself effectively. So looking at the 2 different platforms with PGM and MiSeq, we used, as I mentioned, the FR1 primer set because that's what was available at the time. And what we find is that when you look at the clonotype detection, it was quite similar. The dominant productive clonal sequence was detected in 97% of the cases, and it was concordant. And in fact, when we looked at the exact output, so meaning that the dominant clonotype and any additional clonotypes that were detected, that was exact for 91% of cases, or 32 out of 35. And then 2 cases had minor discrepancy where that additional clonotype met criteria for calling by one platform, quantitative criteria, but not the other, but was still detected if you looked at looked at those additional reads. You could see that it was still there. It just didn't fulfill that 2.5% cutoff, and 10 times against the background that particular criteria. But then let me just briefly talk about this one discordant case by PGM. So this is showing you a portion of that sequence aligned, and you could see that there were this by PGM sequencing, this particular clonotype actually had these 2 different variants to it, and they both represent homopolymer errors, whereas by FR1 and leader sequencing on the MiSeq, as well as the reference, this was the consensus sequence that was identified. And what these errors ended up doing is that these sequences were predicted to be unproductive, whereas by MiSeq sequencing, they were predicted to be, and by the reference, they were predicted to be productive. So this led to a misinterpretation of something that was productive as unproductive. So this was one of the discordant cases that was a major discrepancy. So then we looked at the general comparison of the MiSeq and PGM platforms, and it seems that overall, they were quite similar, with the exception of the total number of reads. We see that with MiSeq, you have a higher total number of reads, and that's entirely expected because we know that with MiSeq sequencing, it has a higher sequencing output, so that's entirely expected. The length of the clonotypes was identical. The clonotype percentages were also, there was not statistically significant. When it comes to evaluating the base quality parameters between PGM and platform, it's very difficult to compare that easily because there are inherent differences in the way that the data is processed. So really, Q30 scores aren't applicable when you evaluate PGM, and even Q20, which is shown here, are not really good measures just because of the difference in the chemistry between these 2 methodologies. And we think that actually a better way to look at this, to look at the base qualities, is to look at the mutation rate differences. And so we looked at those matching clonal sequences, the 48 of them that match between these 2 platforms, and we looked at the mutation rates, comparing those by FR1 and by PGM, and they turned out to be identical. So the correlation linear regression was excellent. But when you compare 2 different measurements by 2 different instruments or by 2 different methodologies, this kind of just linear regression and correlation is really not that great of a comparison because it doesn't really help you identify systematic biases. And a much better way to do that is to look at the differences versus the average between the two methods, and that's by this Bland-Altman analysis. So that's what we did here, and as you could see that there's absolutely no difference at all, because of course those rates were identical by both. Sorry, I'm just progressing. So then we went ahead and now used the MiSeq platform to compare the two primers, the leader versus the FR1 primer sets, to see again what is the clonotype detection. And here it was quite similar, except for that one failure that I mentioned by leader sequencing. This one case had less than 30,000 reads, so it was considered a failure. But still, when you look at the reads that were available, we were able to find that clonotype there. That was identified by the other platforms. So then for those cases that were successfully evaluated, 34 out of 34 had the identical dominant productive clonal sequences. And then there were some what we called minor discrepancies, because additional clonotypes were found by one primer set, but not the other, in only 6 cases as shown here. So possibly maybe this represents an amplification bias. It's not entirely clear. So then also looking again generally at the general output by these two primer sets, we could see that there is a similar, based on this analysis, there was a similar total number of reads. So there is no statistically significant difference here. As expected, the average length, the mean length of the clonotype that you evaluate was much longer by leader sequencing. So this is entirely expected. It was statistically significant. And then as far as the percent of total reads, the dominant clonotype evaluated by FR1 and by leader were the same. And then when we looked at these quality parameters with Q30 scores, you could see that these also, there was no statistically significant difference. These were also very, very similar. So then we went ahead and looked at what we were interested in, which was the mutation rates by leader and FR1 sequencing. And so we looked at the 46 matching clonal sequencing. Of those, 39 were productive and 7 were unproductive. And what we see here is that there is quite a strong correlation between these. But because we're interested to identify any systematic bias, we looked by the Bland-Altman analysis. And what we see here is that there is a slight but consistent bias here, where the FR1 sequencing does generate mutation rates that are slightly higher by about 0.33% compared to leader sequencing. So then we by seeing this bias, we wanted to understand, well, does it actually make a difference, the systematic bias? So then we evaluated the risk stratification of these cases and by these bins. So the clonotypes were displayed here based on bins, and you could see that in the vast majority of those cases, it actually didn't make a difference. This bias didn't really make a difference between whether you sequence by leader or FR1, because they were either unambiguously unmutated or unambiguously mutated, and it really didn't make a difference. But in one borderline case, this was important because by FR1 it was predicted to be unmutated, whereas by leader it falls into this borderline category. So it seems that for those borderline cases, whether you sequence by leader or FR1 does make a difference. So we went ahead to then look at this bias a little further, and we wanted to understand, well, when you sequence with FR1 primers, what portion of the FR1 region do you actually capture? And it turns out that you're actually capturing a very small proportion of the FR1 region. So only 6.5 base pairs, which ends up being only about 9% of the total FR1 region. So you are losing most of the FR1 when you're sequenced with the FR1 primers. But again, does this matter for evaluation for somatic hypermutation? So to address this, we wanted to look at the distribution of the mismatch base pairs, the distribution of the mutations along the V region. And so you could see here that, and for this, we only looked at the productive clonotypes, because that's, of course, what's significant for prognostication that had any degree of mutations. Of course, looking at those that are unmutated wouldn't be helpful. So we looked at the distribution of mutations along the V region, and you could see that CDR1 and CDR2 contribute the highest proportion of mismatch bases for the entire region, whereas FR1 showed the lowest rate of mutations. And that, of course, makes sense, because these conventionally, these are the primers that are used, that were designed, and of course you want to design it against the region that has the lowest amount of mutations, so that you could have a successful amplification of your product. So that makes sense. And of course, when you look at FR1, that corresponds to the scaffolding region of the protein. So you want to make sure that those are conserved as well. So we then wanted to ask, well, what happens to the mutation rate if you completely got rid of the FR1 region? How does the mutation rate really change? So we took the leader output and we just removed the entire FR1 region, and then we compared the mutation rates if you just took the entire leader based sequence versus if you took the leader-based sequence but remove the FR1. How does the mutation rate change? And we do see, again, this slightly higher bias. It's a little bit higher than before. It was 0.33 before, now it's 0.48. So if we exclude the FR1 region from the calculation, you do get a higher mutation rate, which makes sense. And then, but of course, when you look at the mutation rate bins, this again makes really no difference for those cases that are unambiguously unmutated or unambiguously mutated, and it only makes a difference for those cases that fall into this borderline category. So this was our comparison of platforms and primers. And I just before I move on to the next portion, I want to just highlight for you that one aspect of PGM sequencing that's quite beneficial is, of course, the total time, the total assay time, which is much shorter, whereas for MiSeq sequencing, it is significantly longer, because you need, for FR1 sequencing, you need at least 500 cycles, which takes about 48 hours. And for leader sequencing, that's even longer, 65 hours. So there's an advantage to PGM as far as the efficiency in the lab. And another, I do want to point out that for the kits that are available, the number of indices that are available for PGM is 12, whereas the barcodes for MiSeq are 24, so that potentially you could have more samples per run. So having established an excellent performance of the platform, of the MiSeq platforms, we ended up implementing this in our lab because of the requirements for throughput, for homopolymer performance, and also the ability to use leader sequencing. So then we went ahead with the prospective arm of the study, and for this portion, we evaluated we tested 423 unique cases, and these again were predominantly peripheral blood samples with some bone marrow aspirates and some FFPE tissue. And I do want to point out that one thing that we did was we excluded any cases where flow cytometry detected more than one abnormal B-cell malignancy. So if there was an additional small plasma cell neoplasm or another, or if it was even a biclonal CLL, which has been reported, we excluded those as well. Biphenotypic CLL, let's say if it was kappa and lambda, we excluded those just to avoid ambiguity as far as the interpretation. And so then this cohort we studied either by leader sequencing, by FR1 sequencing, or both on the MiSeq platform. And this was our sort of testing schema. We had approximately equal number tested by FR1 and leader. And in cases where the results were problematic, we then reflexed it to the alternate primer set. So problematic cases included a total of 36 that are shown here. And if they were problematic, if they were polyclonal, if we weren't able to identify a productive rearrangement, dominant rearrangement, or if there was a clonotype that was borderline for the mutation rate by FR1, then we reflexed it to leader. So these are the different reasons. Or if there was just an additional clonotype that we were suspecting but maybe weren't quite sure of, so we reflexed it to the alternate to the alternate primer set. And in the end, our overall success rate was determined. So for those cases that were reflexed to the alternate primer but were still concordant with the original analysis, we counted them as successful under the original primer set. And so the overall success rate with a single primer by FR1 was 94.7, and the overall success rate with leader was 97.7. So these are not statistically significant. There any differences here, they're actually quite comparable. So then we went ahead to examine overall what are some of the general parameters comparing these two analysis in this prospective cohort, and there was no statistically significant differences, but as far as the age of these subjects, their sex, the sample type, so there was no difference between leader and FR1 sequencing. We did find that with FR1 sequencing, the total number of reads was higher compared to leader sequencing, which suggested that possibly there is a higher efficiency of amplification with FR1 in at least in our lab, at least in the way that we perform it. And this was statistically significant. And so then we also looked at the output with respect to the clonal sequences that we detected. And in the vast majority of cases, and 80% of the cases that we evaluated, we were able to detect a single productive clonotype, and there was no difference here between whether we sequenced this with FR1 or with leader. The majority of cases were had a single productive rearrangement. We did have some cases, in about 19% of cases, there was a double rearrangement, and here, let me show you those here. So double rearrangement was seen in 19% overall, and again, whether it was detected by FR1 or by leader, it was quite similar. And the majority of these double rearrangements were one productive clonotype with an unproductive clonotype. And as I mentioned before, these are the kinds of cases that are considered to be challenging for prognostication, because we need to understand, well, what's driving the prognosis here, and we know based on prior studies that actually it's the productive clonotype that drives. So that's what you want to look at, and the majority of these cases had concordant status, where the mutation status was concordant. Either both were mutated or both were unmutated, and only in just a few number, in just 5, which represented 8% out of these doubly rearranged cases, only in 8% was the mutation status discordant. And similarly, also, we were able to detect double productive rearrangements in 3.5% of the total cohort. And again, there was no difference between leader and FR1 sequencing. And these, of course, are quite rare. And in the majority of those, again, the mutation status was concordant. And this is similar to what's been published. And lastly, I do want to point out that what we found interestingly was that by FR1 sequencing, it seems that the clonotypes, the percentage of clonotypes that were detected, it was higher then compared to leader sequencing. So your dominant clonotype or all of the clonotypes appear to be higher in the percentages versus leader sequencing. And this was true also for either the major productive clonotype or any of the additional clonotypes. They also the FR1 output generated higher percentages of that sequence. But then we went ahead and looked at the mutation rates across all of the productive clonotypes that were detected in this prospective cohort, and this bar graph shows the distribution by leader and FR1 in these colors, and you could see that again, as we saw in that retrospective cohort, the majority of cases in here were either unambiguously unmutated, meaning a worse prognosis, or unambiguously mutated when it comes to risk stratification. And there was no statistically significant differences between these. And only in a small proportion of cases did we have a borderline somatic hypermutation status, and that was 2.6% by leader and 3.4% by FR1. And again, no differences there. And then we went ahead and we looked similar to what we did for the retrospective cohort. We wanted to understand, well, what portion of FR1 is actually captured when you sequence with FR1, and similar to what we saw with the retrospective cohort. Again, we're only capturing about 9% of the FR1 region, and this was looking on the productive clonotypes. And then we, again, similar to what we did before, we looked at the mutation distribution using the leader sequenced cases, and we again looked at what was the what regions tended to have the most mutations, and those were CDR1 and CDR2 as expected, whereas FR1 harbored fewer mutations compared to the rest of the region, so it had a smaller contribution to the overall mutation rate. So then as I mentioned, there were 36 cases that were sequenced with both FR1 and leader, and the reasons for why we had to reflex to the alternate primer set are listed here. So in one case, it had failed sequencing initially. In 10 cases, there was a borderline somatic hypermutation status by FR1. Three of them had no productive dominant clonotype. Then 8 cases were polyclonal by the initial primer set. And then in a few cases, we wanted to see if there was an additional clonotype that probably wasn't quite meeting criteria, so we wanted to just confirm. So those were the reasons, and this was the summary of those results. You could see that the majority of cases, 24 out of 36, ended up having concordant results, including 5 cases where the initial primer set was not able to detect any clone, and then the second primer set also couldn't detect any clonotype. 5 of those, including one where we only detected an unproductive rearrangement here. So overall, the successful clonotype detection by the individual primers was, as I mentioned, 97.7 by leader and 94.7 by FR1. So those were quite similar. And similar to the retrospective cohort, we again compared those cases that had matching clonotypes. We compared the mutation rates, and there is a strong correlation similar to what we saw before, and we looked by the bland Altman analysis, and again we see that there is a bias with FR1 of a similar percentage, 0.3%, as similar to what we saw before. And when we evaluate by these bins, you could see, of course, that here there are many more cases that have a borderline somatic hypermutation rate, but that's because those are the cases that we selected for this particular analysis. So this is just showing you that we we confirmed our selection bias here. So this concludes what all of the analysis that we did, and I just want to summarize with a few slides of conclusions based on our experience. So we find that PGM and MiSeq sequencing provide equivalent output, with the exception of a rare case where there was a homopolymer issue. Of course, this is a known limitation of PGM sequencing, but it could lead to an erroneous interpretation of something that was productive but was interpreted as unproductive. And we did notice that PGM has lower total sequencing capacity compared to MiSeq. And so what that means is that evaluating cases for MRD analysis for minimal residual disease or monitoring those clonotypes would be limited on this platform. However, when it comes to the needs of the laboratory, that's what should be really used to determine which platform you want to select, and your experience with a specific platform. So our recommendation is that it seems that the output is quite similar. So really, it should be the needs of the laboratory that should guide the platform selection. Then when it comes to the primer evaluation, so leader versus FR1, we do find that FR1 captures only a small proportion of the FR1 region, but that portion does have low frequency of mutations for the overall evaluation of the mutation rate. However, this still leads to a consistent small bias of the mutation rate with FR1, which is on average about 0.3% higher than by leader. And if you remove the entire FR1 region, then that difference can be as high as 0.48%. But overall, when you're looking at CLL samples, this had little impact on the somatic hypermutation status because borderline cases are quite rare. So overall in our study, that was 2.4% of cases. And so overall, also the success rate of leader versus FR1 was quite comparable, as I showed you. And the success rate of detecting a clonotype was even higher when you looked at the combination of both primers, so that when you weren't able to detect a clonotype by one, or if there was questionable results of your reflexes to the alternate primer set, that your success rate went up. And of course, compared to conventional method, this is much, much better. FR1, we did notice that FR1 sequencing has higher efficiency, at least in our hands. FR1 also has a higher number of total reads and a higher proportion of the dominant and additional clonotypes compared to the leader. Again, at least in the perspective analysis that we did. The leader, as I showed you, leader requires longer sequencing, a longer time on the instrument. And we do want to comment on the fact that mixed runs, where you include both leader and FR1, because of the longer sequencing that's required for leader, that may generate over-sequencing of the shorter fragments for FR1. And this can have implications for the quality of the run, and it can also have implications for the lab workflow, because if you want to avoid this over sequencing, and if you want to just sort of have leader only runs, then that can affect the turnaround time when you're looking for just having a batch that with sufficient enough samples just for leader sequencing. So in our hands, we find that it's important to be aware of this over sequencing of shorter fragments that can happen. So at least from our data, it seems that sequencing with FR1 and reflexing to leader for those challenging cases may be considered for CLL cases. Of course, this requires further studies and studying it in multi-institutional comparisons, looking for standardization. but we do think that FR1 sequencing is quite comparable to LEADER, as you saw in the majority of cases, where the mutation rate is unambiguously mutated or unmutated. And lastly, when it comes to detection of these challenging cases of the multiply or doubly rearranged immunoglobulin molecule, this has been previously reported, as I mentioned. We do find that that with NGS sequencing, it's observed more frequently at 19% than by conventional methodology, and this could be due to the higher sensitivity of NGS, but also because we're using genomic DNA rather than cDNA. And also, NGS is quite advantageous because it allows you for the evaluation of the second clonotype, whether it's at all related to the first clonotype. You can at the same time obtain information on the functionality and somatic hypermutation status. So we find that quite advantageous. And in those cases where there's a discordant mutational status between your two rearranged immunoglobulin sequences that you've identified, those cases are quite rare with the discordant status. So in our cohort, it was only 2% and only 10% of those cases with more than one clonotype. And as far as the doubly productive cases, those were, as I said, were quite rare overall. And the ones that with a discordant mutation status, there was only 3 cases in this fairly large cohort that we identified. Now we don't have any additional, follow-up prognostic information on these cases, but it would be interesting to collect them and see additional how those patients behave, those study subjects. So that's all I have as far as what we did for this particular work. I want to acknowledge all of the people who contributed to this work, including Dr. Arcila, Wayne, Mustafa, Monica, and I also want to thank all the in vivo scribe partners, and I'll be happy to take any questions if there are any. Thank you.
Thank you, Dr. Petrova, for your excellent presentation. We'd like to address some questions now for today's listening audience. The first question that we got in was, do you think IGHV should be done for all CLL patients, as this is currently not part of routine practice?
Well, we do think that somatic hypermutation status has significant implications on prognosis. It has consistently, together with P53, it has been identified in multiple studies as an important prognosticator when it comes to both how the patients will do and whether, how early they should be started on treatment. So at least in our institution, we do it on all CLL patients. So I believe the recommendations are from NCCN, from Eric. I believe that the recommendation is to do it on all patients. Thank you.
The next question is, why did you choose to add the 10x against background as criteria?
So that was, I believe, part of that part of that came from the manufacturer recommendations. I believe the manufacturer recommended 3 times the background, and that also comes from the conventional interpretation when you're looking at fragment analysis for clonal peaks, right? The conventional Biomed 2 criteria describe it having at 3 times the background, the polyclonal background. So that sort of evolved out of there. And based on our experience, as I mentioned, we initially, the publication from 2019, we looked at something like 1,000 different cases of a variety of B-cell neoplasms and interpretation with the NGS platform. And that's how that evolved, because we wanted to avoid any sort of pseudo clones. And, the interpretation is slightly different when you're looking at NGS and you're able to see the different clonotypes.
Thank you. Well, we have now reached our closing time. We'll answer any unanswered questions via email. On behalf of AMP and VivoScribe, we want to thank everyone for your attendance at today's webinar. Again, we want to thank Dr. Petrova for a wonderful presentation. Please note this session has been recorded, and these presentations will be available via the VivoScribe website. Thank you again. The session is closed.
Thank you.